Hear me?
Yeah, I can hear you. Okay.
All right.
So welcome, everybody, to our grand rounds today. I'm going to, this is John Santapietro. I'm going to introduce Dr. Sanders and in a minute and tell you a little bit about how excited I am that she's joining us, both for the topic and for who she is. But before that, let me just walk through the ground rules or the to-dos that we do every time, which is that we'll hear from Dr. Sanders for an hour until 1, and then we'll have 15 minutes of Q&A. And as usual, people can get questions to me in 3 ways. You can either put it in the chat feature, which I'm amazed that I even keep saying that because no one does that on this program, but occasionally actually somebody does. I shouldn't say that. I had a couple last time, which is that square thought bubble on the left, top left, if you're on a computer and have that feature. You can also send me an email. Most people do it that way, or you can text me. So, and I'll either read your question, or if you want me to unmute you, do that as well. And so I'm going to pull up now, Marilyn. I don't see your slides, so I don't know if you want to.
I haven't shared my screen yet. Do you want me to share it?
Yeah, why don't you share it? Because I was seeing a black screen.
Okay.
And that might. Sometimes it gets wonky in this phase. So as you're sharing your screen and slides, why don't I start with the bio? Yep, I see your screen.
Yep. See my slide?
And now I see your slides.
Okay.
So Dr. Marilyn Sanders, I'll just read her bio, then I'll say a little something. So Dr. Marilyn Sanders is a board-certified pediatrician and neonatologist who cares for critically ill babies, infants, and their families at the Connecticut Children's Medical Center, Newborn Intensive Care Unit, NICU, in Hartford. She did her pediatric residency at the University of Connecticut School of Medicine, her fellowship in neonatal perinatal medicine at Johns Hopkins. She's a professor of pediatrics at UConn School of Medicine. She also provides neurodevelopmental follow-up for babies and infants up to 3 years old. Her scholarly interest is in providing trauma-informed care, that's a term we know well, to hospitalized newborns, infants, young children, and their families. Her focus is the impact of the autonomic nervous system's sense of safety, danger, or life threat on our emotions and behavior. She lectures throughout the United States and Europe. She's authored papers and book chapters on trauma-informed care for young infants, children, and their families in the hospital setting. Dr. Sanders and her co-author, Dr. George Thompson, are currently under book contract with Norton & Company. Their book, The Polyvagal Theory and the Developing Child, Strengthening Children, Families, and Communities, will be published in July of this year. We'll want to take a look for that, and discusses implications of the polyvagal theory for the well-being and development of infants and children and adolescents. She's also on the advisory board of the Polyvagal Institute. She also knows and did work with and learned from Ed Tronick, who many of you know. I very regularly use his still face experiment video, which is a very powerful video for teaching. So two reasons I'm really excited to have Dr. Sanders here. One is that she's one of my favorite people, and really makes a difference in the world, has made a difference, continues to make a difference in the world, and her passions are very much aligned with ours, which is so wonderful for somebody that's not a psychiatrist. And secondly, this topic, I was just talking with people this morning, and wondering why do we so rarely talk about this attachment, and we need to be doing this more. So this is a great way to, let's say, kick off even more of a dialogue on attachment. And so with that, without further ado, I will turn it over now to Dr. Marilyn Sanders.
Good afternoon, everybody, and thank you. To add fuel to the fire, I can't see any of you, so I am literally speaking to my screen. which is going to be interesting just to see how this potentially impacts my own presentation style. I look forward to this. I have many, many friends in the Institute of Living, and I am very excited to hear your feedback on what I have to say today about secure attachment, which is potentially a portal or pathway to improving population health. These are, of course, your CME slides. I'm sure you know them well. I won't dally on them. Thinking about the objectives for today, as a result of participating in this learning activity, these are the objectives. But basically what I want you to think about is the impact of your own autonomic nervous system, your unconscious awareness of whether you are safe, in danger, or in a life-threatening situation. And think about how that impacts your own behavior, how that impacts your patient's behaviors, and how that might potentially impact attachment processes. So I started looking at the news in the 1960s, and a very vivid image to me was Jackie Kennedy coming in to Bethesda Naval Hospital to visit her dying son, Patrick. And on the left, you see Patrick Kennedy, who was a 4.5-pound, 34-week gestation infant who died of respiratory distress. We've come a long way in the last 50-plus years, and survival for babies of his age and size is now virtually guaranteed. Survival for even younger and smaller babies is very high, but there's a price paid for that survival. And you see that price in the slide on the left from Dieter Wolk's work. He is a psychologist in Germany. And what he's done here, he shows you both in orange bars for children and adolescents and blue bars for adulthood, the challenges of surviving, in this case, extreme prematurity in terms of the impact on your later well-being. So you can see, for example, that there is a significant increase in cerebral palsy in childhood and adolescence. You can see that there are significant diminutions in important social outcomes, including things such as education and ability to participate in long-term social relationships. And of course, very well known to you, and in about the middle of the slide, is the dramatic increase in children and adolescents now diagnosed with autism spectrum disorders, many of whom have been preterm. I'm sure to some of you, those of you who don't necessarily know me, it might seem odd to you that a newborn intensive care specialist has an interest in social connectedness and attachment. But I would propose to you that the technological tools that we have, although dramatically better than in the days of Patrick Kennedy, have reached in some respects the limits of their potential to improve outcomes in the newborn intensive care unit. And instead, what we have, I think, is in terms of the biggest tool, the greatest tool, the most underutilized tool in our toolbox for promoting outcomes is actually parent-infant relationships, social connectedness, and over time attachment. And this is an actual baby who was in our NICU many years ago. She was deathly ill. Her mother was at the bedside 100% of the time that she could be, even was there during surgeries that the baby had, and this little girl had a marvelous outcome. I was really lucky in my career when I was in undergraduate school preparing to go to medical school, having no idea that I would end up doing pediatrics or newborn intensive care. A wise, older female physician said to me, "You have to read this book." And this book was John Bowlby's Attachment. And I consider myself extraordinarily lucky, particularly as a neonatologist, that I was introduced to attachment theory so early in my career. So we're going to start by thinking of the biological expectancies of the newborn and young infant. For those of you who have been parents, are parents, for those of you who have had nieces, nephews, whatever, hopefully you all understand that this baby expects something, at an unconscious awareness, of course, of his or her adult caregivers. The baby expects them to be in both physical and emotional proximity. The baby expects sensitivity and attunement from the caregivers. The baby expects contingent responsiveness. He makes a move, mother responds. Mother makes a move, baby responds. And so it goes as the two continue to engage socially and over time become socially connected in an important way. And the definition that I'm going to use of social connectedness, I attribute to Stephen Porges, who has been essentially a mentor of mine. Stephen is a neuroscientist who has, over the last 25 to 30 years, developed the polyvagal theory, which directly relates our autonomic nervous system to our emotions and our behaviors. And he uses social connectedness in the following way. He defines it as the ability to mutually, meaning synchronously and reciprocally, regulate physiological and behavioral state. And as you look at the pictures in front of you, it should be quite clear that what is going on there isn't just a handshake or a kiss on a dog nose or a little boy cuddled up with his father. It is an important co-regulatory process. And that process is a precondition for attachment that follows later in the first year. As we think about social connectedness and felt security, a term that people attribute to Bowlby, we can understand then that for the infant mammal, social connectedness is a biological imperative. Simply cannot survive, be they the little chimp, the golden retriever, or the human newborn, without to adult caregivers. And given their expectations of that connection, the worst thing that can happen to a young infant from a social emotional standpoint is being separated from their caregivers. And we know that given the importance of social connectedness, we are all constantly scanning our environments to see if there's potential danger afoot. So that struggle between affiliation and exploration, particularly as infants get older, is dynamic and ongoing. Stephen Porges, to capture this sense of unconscious awareness, had to develop a term for it because perception involves the frontal cortex. He wanted to refer to a process that is entirely out of awareness. And such, he named this process neuroception. And neuroception, very simply, is the unconscious scanning for safety or danger in your environment. And your environment has two components to it. There's your external environment, which is what's going on directly in your environment. Where are you sitting right now? What are you feeling in the room? And then there's the relational component as well. My relational component, I think, is a little challenged at this moment, given that I can't see any of you. And then there's the internal sensory experience or interoception. What does that external environment do to you at a visceral level? And the two of those together, meeting, give you a neuroception of whether you are safe and calm and secure, whether you are potentially in a dangerous situation, or whether indeed you are in a life-threatening situation. And you can see that those arrows go both ways because, again, it's a dynamic process and can change very quickly based upon cues from your environment. So I want you to keep these thoughts in mind as we now segue into a discussion more directly of attachment and think about how the young infant's and his or her caregiver's neuroceptions affect their capacity to attach over time. And we're going to start with a very brief history of attachment theory. So I was introduced to Bowlby early, but I had no idea how Bowlby got started for a number of years. Bowlby was a psychoanalyst, and he provided services in a child guidance clinic. And you can note the year on this publication, 1944. So the publication was during the war, and these observations were obviously occurring during wartime in England. And in that child guidance sample, he noted that there were 44, as he named them, juvenile thieves. And he further noted that a third of them had what he called affectionless psychopathy. And as he started looking at that population, he noted, as you can see in the gray bars in the figure to your right, that 86%, or 12 out of the 14, young juvenile thieves who had, as he called it, affectionless psychopathy, had had a prolonged, greater than 6-month separation from their mothers at 5 years of age. And this was the beginning of Bowlby beginning to think in a systematic fashion about the principles of attachment. Bowlby's theory of attachment behavior, and this is totally unfair to Bowlby, but we have a lot to do in a short period of time, so I've tried to summarize very, very briefly in sort of little sound bites how we would think about attachment behavior. And one of the most important things that Bowlby concluded was that attachment behavior is goal directive. And it is an instinctive proximity-seeking behavior. So just as we talked about the expectancies of the human newborn, as we age, and certainly throughout early childhood, we want to know where our attachment figures are. Are they close? Are they available? Are they responsive to us? And in a very prescient way, I think, given where the whole field of genetics was at that point, which was essentially pretty much non-existent, he noted that this attachment behavior was some product of genetic endowment with the environment that the young infant or young child was in. And when you think about what we now know about epigenetics, for example, and the transgenerational transmission of stress, for example, he really was prescient in calling attention to this interaction between the two. And he also noted, as we talked about with the expectancies of the infant before, that attachment behaviors maximize the chances of survival for the infant or young child. And of course, attachment behaviors and the attachment system are an important part of what Bowlby called the internal working model of relationships. So for a young child, the sense that that young child has of his own worth in the world, how he expects people to behave toward him in the world, what he deserves in the world, are largely set in place by those earliest relationships. And it's not that these can't change. They are not static. They can change. But those first few years and those critical early relationships set the template for the early model. And Costello says, and I think this is really a beautiful way of describing the internal working model, that the internal working model is a kind of guidance system that tells us what to do and what to expect when we're with another person. They are scripts for social interaction. As we keep this in mind, we also have to understand that when we are dealing with the human newborn and young infant and young child, we are talking about a brain that is still under construction. So just imagine, for example, for those of you who know anything about the population that we care for in the NICU, when you look at a fetus now baby, for example, who's born at 24, 25, 26 weeks gestation, as many are, look at the processes that are going on, neuronal migration, synaptogenesis, apoptosis, all very actively going on. And unfortunately, for those tiny preemies who are born, they're going on in an environment that is wholly unsuitable for this very fragile, very vulnerable human being. Even as we get past birth and as we get into early infancy, as you can see, myelination, which doesn't start until the third trimester, is still extremely active. Synaptogenesis still extremely active, and apoptosis continuing to go on as well. So just imagine now how the coupling of whatever your template is that you were born with is impacted then by the environment in which you are born, be it a newborn intensive care unit or into the home of your natural providers, and how the two influence each other. So the question, as we think about attachment and its implications for health, really are focused upon three different principles. And if any of you are really interested in this, Maunder and Hunter are psychologists who have written extensively on attachment style and health. And to them, the principal components of thinking about this include that the infant attachment behavioral system is linked to the biology of stress, that attachment styles, so they say, are relatively stable from infancy to adulthood, and that adult attachment systems are also linked to the biology of stress. Many, if not most of you, are hopefully aware of the concept of allostatic loading. And this is a beautiful chart, nomogram, whatever you want to call it, that I think illustrates the complexity of the processes that are involved as we start with early life. And as you can see, all the way up at the top, you're actually looking at the fetal environment. So what is, for example, the fetus's epigenetic susceptibility? Then early life stress, which is the period of time, of course, in which these important attachment behaviors are ongoing. So we think about things like developmental stage. What a child experiences at one developmental stage may have a very different impact than experiencing it at a later one. How long is it ongoing? And from the standpoint of the type, if you were to look, for example, at the adverse childhood experiences about which Felitti and others have written so dramatically, most of the adverse experiences are actually disruptions of connectedness, as opposed to the kinds of things that we would typically think about, like frank physical or sexual abuse. And then below, of course, are all the allostatic processes that can result from these early life stresses, which over time compounded by behaviors that may indeed be precipitated by the types of stresses the individual experiences, altogether has to bring the organism into some form of physiologic, biological equilibrium. And if we're lucky, and if we've had good enough early life experiences, and if bad things don't happen to us along the way, generally, we have a pretty good adaptation and some resilience. If, on the other hand, we are born into an environment which is bereft of the kind of early life experiences that we know foster good connectedness and attachment, and then we get unlucky again, and other things happen to us and compound each other, and then those all play out in allostatic processes, we can end up in a maladaptive or seemingly maladaptive situation, because keeping in mind that the organism strives to survive, things that we would label, ourselves would label maladaptive, are not necessarily so when you look at what the individual is experiencing in his or her life. So let's talk for the next few moments about the infant attachment behavioral system and the biology of stress. And of course, the first environment that the infant experiences is the fetal environment. And we know that the fetal environment in which the baby essentially is dependent 100% upon the mother, her placenta, and her physiologic neurobiologic processes is the first niche, eco-niche, that the infant experiences. And there's some really interesting things that go on in the fetal environment vis-a-vis the hypothalamic pituitary adrenal axis. So we know that corticotropin-releasing hormone, known by most of you as CRH, is released by the placenta into the fetus and into the mother. And as opposed to the negative feedback system that we experience, where as our cortisol goes up, our CRH goes down, cortisol increases placental CRH production in utero. But nature is pretty smart and adaptive. And there is actually an enzyme in the placenta, 11-beta hydroxysteroid dehydrogenase 2, a big mouthful, that oxidizes cortisol into inactive cortisone, protecting the fetus against the heavy load that they might otherwise experience if mothers are terribly stressed. And nature is also really smart in that those enzyme levels fall near term because, as many of you are aware, near term, the cortisol surge is critical to promote fetal lung development. As we then move from the fetus on the left, which, as we talked about, is the eco-niche in the womb, to the extrauterine environment, the parental or caregiving environment becomes the eco-niche for the baby. And it's social engagement coming on board that regulates both members of the dyad. We have learned a lot over the years from the lab of Michael Meany. Michael Meany is a Canadian neuroscientist who found that a particular type of rat had very distinctive grooming behaviors that separated out into some rats that seemed like they were just natural mothers. And they were high licking and grooming rats. And you can see in the illustration, they got their babies around them. They are essentially a family. On the other hand, there are low licking and grooming rats. And they leveraged this natural biodiversity among rats to do some absolutely brilliant experiments. And the system that they looked at is predominantly the hypothalamic pituitary adrenal axis. And what they noted was that there was a very direct relationship, as you can see on the right, between maternal licking and grooming and the mRNA for the glucocorticoid receptor. Well, how does that enter the equation? Well, the more glucocorticoid receptor that is available, the more it's available to scavenge free cortisol and take it out of the system. So one way of looking at this would be to say that when there's a lot of free cortisol available, not only are you in a situation in which the mammal might be incredibly stressed, but you are also potentially in a situation in which they have simply overwhelmed the number of receptors that are available. One of the most interesting things about this whole thing is that if you cross-foster those rats, so you take a low licking and grooming rat and put them with a high licking and grooming mother, guess what happens? The adult rat looks more like the mother to whom the rat was fostered than the biological mother. And I think that gives us all great hope to think about the future for children who are potentially born into adverse circumstances, that it's not binary. It's not all or nothing. Either you have a good situation or you have a bad situation, and it just from there increases or decreases inexorably. Barry Lester, who is a psychologist at Brown, has been able to duplicate Meany's work using maternal breastfeeding as a proxy for high licking and grooming. So people could take issue with this because obviously mothers who don't breastfeed their children for one reason or another, be it medical or choice, can also have fine relationships with their babies. But unless they were to bottle feed in particular ways, it would be very hard to have the kind of skin-to-skin contact that breastfeeding mothers have perforce when they're breastfeeding their babies. So they looked at a sample, a cohort of term healthy infants whose mothers did or did not breastfeed. And they looked for markers for methylation of the glucocorticoid receptor. And methylation, as many of you know, is associated typically with impairment of certain enzymatic processes. So increased methylation in general isn't good. And what they found at 5 months, and you can see in the blue bars, the low breastfeeding group, and in the red bars, the high breastfeeding group. And what they found was that the mothers who breastfed had decreased methylation of sites that were associated with the glucocorticoid receptor promoter, and they had decreased cortisol reactivity. We know that attachment also impacts the hypothalamic pituitary axis in older children. So in this particular study, toddlers in a primary care pediatric clinic who had come in to have vaccinations had salivary cortisol samples taken both at arrival and after the vaccines. And what they found was quite interesting in that there was a significant difference based upon whether the children were securely or insecurely attached, depending upon whether the family was experiencing other stressors, such as living below the poverty level. And you can see on the right panel that for the babies who had secure attachments to their mothers, and in studies like this, the attachment style was assessed using the strange situation. You can see for the secure kids, they came to the clinic, they got their shot, and an hour later things are okay. But you can see that for those who were insecurely attached and living in poverty, that there was a dramatic increase in cortisol reactivity. We also know that attachment modifies the inflammatory response, and I think this is probably one of the most important outcomes that we could potentially be studying. When we look at all of, I'm just going to call them the disease states with which we are familiar now that are associated with chronic illnesses, and think about the inflammatory load that is associated with them, I think that this is really important information for people to know. So this population was a population of mothers who were depressed and had been assessed for their depression. And it wasn't the degree of the mother's depression that seemed to impact the baby's inflammatory load. It was whether the baby had a secure or insecure attachment to the mother. And that's fascinating, particularly when you think about the rates of depression in this country. And, you add the COVID epidemic on top of that. And I think that this is the kind of research that we really need to be doing to help us understand where are the points at which we can potentially intervene. And sadly, we know through the Romanian child institutionalization, a brilliant set of studies done by Charlie Zena, Nathan Fox, et al., that institutionalization affects your telomere length. So telomeres are at the end of chromosomes, and they are reflections of cell aging. Longer telomeres is better, shorter telomeres is not. And what we see in this illustration, based upon for both boys and girls, that the length of time a child spent institutionalized was directly related, particularly in the girls, to their telomere length. And just to back up for 1 second, for those of you who may not know the Romanian child experience, during the Ceausescu regime, when there was a severe limitation on the number of children that parents were allowed to have, many children were institutionalized in orphanages in which care was horrendous. Zena, Nelson, and Fox, because we didn't really know when the Romanian experiments started, went to Romania after getting IRB approval and randomized children either to go into high-quality foster care or to remain institutionalized. It sounds brutal now, but we did not have the data. And what you can imagine, as they found that those children who were adopted out into high-quality foster care at less than 17 months of age had dramatically improved outcomes compared to those who remained institutionalized. So let's move on then to talking about stability of attachment styles. This is data that should be, and probably is, obviously familiar to most of you. Attachment styles were first identified by a student of Dr. Bowlby's, Dr. Mary Ainsworth, and she developed the strain situation paradigm, where a young child basically is with his or her mother in the presence of a stranger. And they interact for a while, the mother and the child. The mother then leaves the room, and the child has an opportunity to interact with the stranger. The mother then comes back into the room, and the attachment style is assessed based upon the way in which the child reunions with the mother. So for children who are securely attached, they will welcome their parents back in. They will be very happy to see their parents. There will be no ambivalence on their part about the fact that they are joyful that mom or dad is back. For children who have ambivalent, anxious attachments, they will be both wary of strangers and will have a difficult reunion when mother comes back. It may be excessive crying, difficulty reattaching. It's just as if, where did you go? Why did you leave me? And I just can't get enough of you in a way that feels right. Children who have avoidant attachments will potentially behave as if the mother doesn't even exist. They will ignore her. They will go under the table. They will just continue doing what they potentially have been doing. And then May and Solomon added a fourth type of attachment, which has become, I think, increasingly important in understanding the impact of attachment style on later behavior, the disordered attachment. And the disordered or disorganized attachment is one in which the child has no clear either joy on return, avoidance, or anxiety. It's just confused. She doesn't really know what's going on or how to behave. And of course, as all of you know, it is disordered or disorganized attachments that are so frequently involved in patients who turn out to have significant psychopathy. Beatrice Beebe is another psychoanalyst who has done brilliant microvideo analysis of interactions between mothers and their young infants, starting as early as about 4 months of age. And what she has found is that if you look at these pairs, and they essentially do a still face. So initially, the baby interacts with the mother in whatever way they would typically interact. The mother then turns away from the baby, removes her face, and the baby then interacts on his or her own. And most babies, at least those who are securely attached, will become quite disorganized and upset when the mother has removed herself. And then the mother comes back to the baby, and we note what the tracking style is. And in those populations, what Beatrice Beebe found was associated with secure attachments. The tracking system of the mother was flexible. She interacted with the baby in ways that were appropriate. She could allow the baby, for example, to look away from her and not get upset by it. However, there were two types of insecure attachments that she noted. One she called the preoccupied interactive regulation high tracking style. And those are the mothers who are in their baby's face 100% of the time. They cannot let that child rest. They cannot let that child gaze avert because it feels too threatening to them. And then on the other end of that are the mothers who essentially are so preoccupied, so immobilized, so low tracking that it's really as if their babies are not even in the room. And imagine what that would be like from the baby's standpoint. And what I've attached to that is the sense when we think back to Stephen Porges' neuroceptive model. So the secure attachment feels that he or she is in a safe situation. The preoccupied high tracking, it feels dangerous. And then the preoccupied low tracking, it must feel to those babies like their very lives are threatened by the absence of the mother. If you look at a general population, different papers, you'll find anywhere between 50 and 60% of individuals are typically secure. About 15% are insecure avoidant, so those would be the low tracking. About 9% are insecure ambivalent, so those would be the high tracking, and then about 15% would fall into the disorganized category. However, if you look at a population of maltreated children, we find that only about 9% are secure. 28% are insecure avoidant. 15% are insecure ambivalent. And a full 48% have disorganized attachment styles. So one of the premises upon which Maunder and Hunter based their hypotheses was that attachment styles are stable throughout life. Well, are they? And the answer is it depends upon the population that you are looking at. If you look at a population of middle-class white children who are assessed at 1 year of age and 20 years of age, 72% matched attachment styles. And obviously the young adults, typically the adult attachment interview is used, but there are some other models as well. If you look, however, at high-risk children at a year of age and 18 years of age, comparable ages, only 39% matched style. And if you look at adult women, 27, 43, and 52 years of age, 50 to 60% matched style. And the drift in attachment styles was typically toward avoidant attachment styles related to childhood adverse experiences. The third premise of Maunder and Hunter was that adult attachment systems are also linked to the biology of stress. This is some very nice work done in, again, this is a group of depressed mothers who were pregnant women, and they looked at these mothers based upon whether they had secure or insecure attachment styles, and also whether they had recently experienced a stressful life event. And not surprisingly, oxytocin levels, oxytocin being, of course, as we all know, the love hormone, were lower in those who were insecurely attached. And they were also lower in those who had had a recent stressful life event. So it's as if you start out already behind the 8 ball with an insecure attachment, and then life is random or life is predictable even, and you have additional stressful life events, it is just hard to win. This slide is actually a theoretical model, but I liked it because it talks in a way that certainly is biologically plausible. And this article was looking at the relationship between attachment styles and dementia, which is a topic that would be very interesting to many of us at the stage of life we're in. And they had a concept called brain cognitive reserve, which I thought was really interesting. I think another way that you could think about that was resilience, and looked at a model in which they thought, well, if you do have a secure attachment style, what are the kinds of things and activities in which you would engage, and what are the types of affect that you might have which would potentially be protective against dementia? And you can see up at the top of this diagram, we of course have our early life experiences, which set the stage for our attachment style. If you have a secure attachment style, then presumably, and if your internal working model is good, and those two kind of go hand in hand if you're truly secure, then presumably you're very flexible. You've got a lot of resourcefulness, and you have a positive image of yourself and others. And just imagine, of course, what flows from that then in terms of your ability to engage with your environment, both locally and your larger environment, how you will benefit from social support, how you will have decreased vulnerability, even if bad things happen, to shutting yourself in, isolating yourself, which of course is potentially also going to impact then upon your ongoing or continuing sort of activity schemata. One of the things I think about, for example, in the COVID era is what about all those older people who played bridge and poker and pinochle and mahjong, and what's happened to them just in terms of their brain cognitive reserve, as those of them who are trying to be COVID component no longer have those activities to keep them active. Getting back again to biological processes that impact health and well-being, again, talking about telomeres, this is a very interesting study that comes from Finland, which many of you probably know has one of the highest life expectancies and lowest infant mortality rates in the world, always way up there. And this looked at an epidemiological cohort that was randomly selected, about 900 adults, and they were divided into those who had anxious styles versus controls. And what was really interesting is that the red bars here represent those who have had either frank anxiety disorders or subthreshold. And then the controls were the blue dots. And you can see that over time, of course, relative telomere length does get shorter, irrespective of who you are. But when you look on the right-hand side, and now we're looking at the population that had anxiety disorders, and look at the impact that adverse child experiences had on their telomere length. So that by the time you got up to more than 4 adverse childhood experiences, there is a dramatic impact on your telomere length. So let's transition over to talking about attachment style and health outcomes. So Bartholomew and Horowitz did a very nice job for us in terms of defining an attachment style paradigm for adults that includes an internal working model and attachment style. And this is the model that people use frequently when they talk about health outcomes. A few studies to familiarize yourself with. This is a very nice study from the Minnesota Longitudinal Study of Risk and Adaptation. If you don't know this study, you should. This is the work of Alan Sroufe. I hope I pronounced that correctly. And they followed a large cohort of high-risk families with babies who were born in the mid-1970s. These were all first-time mothers living below the poverty line, so a very high-risk sample. And as you can see, looking at the nomogram, for those families where they had both an early maternal sensitivity, what they call the secure-based script, which isn't just the assessment of security, of style, but also having a coherent script that went along with it. You can see that both of those resulted in decreased cardiometabolic risk factors at ages 37 to 39. And the cardiometabolic risk factors that they looked at included blood pressure, BMI, waist to hip ratio, and C-reactive protein. Important information, particularly thinking about the extraordinary risk that this population is at for severe chronic diseases. Paul Cianikowski, who is a psychiatrist who works in primary care in the state of Washington, has done a lot of work looking at attachment style and health outcomes, particularly in patients who have non-insulin dependent diabetes. And what Cianikowski has shown in multiple studies is that for those individuals who have the dismissing avoidant attachment, and keep in mind, of course, that as we were speaking previously, we talked about the fact that if there's going to be attachment drift over time, it is frequently toward a dismissing attachment style. And as you can see, that both in terms of general diet, exercise, smoking habits, and foot care, those who had dismissing attachment styles were far more likely to end up in the lowest quartile of patients. And then finally, and this is a proxy, obviously, for attachment style. This is a large meta-analysis done by Holt Unstad, also a wonderful researcher in this field. They looked at a meta-analysis with over 300,000 participants looking at the relationship between social engagement and mortality risk, and found that there was a significant odds ratio in favor of those individuals who had the most engagement, particularly for complex measures of social integration, which is what I would call probably social connectedness. So that takes us, in the last few minutes, to the implications for our work. There's a clear message to policymakers here. And that is that we need, and I know I'm speaking to the choir, to support and fund strategies that raise families out of poverty and reduce ongoing adverse experiences to promote secure attachments and enhance health. That goes without saying. But what about us as providers? Herbert Adler is a really interesting guy. He is an internist and psychiatrist who has written a lot about the socio-psychology of the healthcare provider-patient relationship. And in one of my favorite of his quotations in some of his work, he talks about establishing provider relationships requires the person-to-person attunement that is essential for the development of the newborn and potentially the well-being of his mother or other family around. So as we go back for a moment in the closing minutes here before we take questions and think about how this potentially impacts us as providers, I ask you, thinking of the neuroceptive model, to consider how you are in this particular moment, in this particular external environment, and your own internal environment. Do you feel safe and secure? Has this talk got you agitated or sympathetically driven? Or have you actually become immobilized, death feigning? I certainly hope not. And then I would ask for you to think, for me, with just a moment, about the following model. And one could do this based upon, ignore the blue for the moment. This is the work of Pietro Monaco, who looks at health outcomes based upon attachment styles and talks about the fact that between partner A and partner B of any dyad, there's obviously going to be a relationship orientation that that individual has based upon early experience. It's going to lead to dyadic processes that impact their behavior in the relationships, and there's going to be mediators of those behaviors, which over time, of course, when we think about that neuroceptive model and the internal environment, are going to affect the physiology, affect, and health behavior, leading to eventually health and disease outcomes. So I ask you to think about yourself. What was your early experience? Are you someone who can seek out and accept support? Are you able to engage and respond? And what is your physiology and neuroceptive temperature in this moment? And then think about somebody that you would consider a provider for yourself. And for a moment, think about what might have been his or her early experience. Are they able to offer support and extend care? Are they engaged, responsive, and attuned? Are they able, at times of stress for you, to correlate you? And if you really want to take this to the nth degree, not now, but later, think about your patients as the you, and the you as your provider, and ask yourself, what are you able to give to those patients? So at this point, I will conclude. I'm happy to take questions. I end every talk of mine with my best teachers, known to a fair number of you out there. My daughter River, my son Matthew, my son Ian. They are definitely my best teachers. There is no question about it. So I would like to, whoops, I went out. I'd like to thank you, and I'd like to thank all of them. And I think I lost my
screen. There we go. Can you see? Can you hear me?
There
Marilyn?
we go. I will. Yes, I will. I'm going to stop sharing. Now I can.
Can you hear me?
Yeah.
You can?
Okay. I can.
So, wow. Okay, so this is the part of the program where I usually say something like, see, I told you so, or see what I mean, and make this transition. And it's gonna be challenging because I have a lot of questions and a lot of comments. It's also really interesting. What a wonderful presentation in so many ways. I mean, to take something at once, it's sort of something we kind of know about, but it's really complex, and you break it down in such a simple way It makes it but there's complexity to it. The other thing that's really cool is my experience was you were able to hold this group in your mind, even though you said you couldn't see them. Now I could see, right, them. I was getting, dialoguing with them. And I can just tell you people are really excited about the presentation and would love to do more work with you. Now let's see how many we can get to. The first person I'm going to go to is I'm going to unmute Laura Saunders, who you may know is one of our leaders. Dr. Saunders runs our LGBTQ IOP PhD and is one of the leaders here on campus and as somebody I think that knows a lot about attachment. And Laura, can we hear you?
Yeah, can you hear me now?
I can hear you.
Yeah. Yes. Beautiful. Yes. So I absolutely love this presentation. You and I could probably have a several-hour conversation with some of these topics. So I have kind of a question and a comment. I'll start with my comment first. So I've been spending a lot of time in the bad weather watching Netflix. So I'm going to strongly recommend a show. It's a British show called Call the Midwife. It's set in late 1950s, early 1960s, the East End of London. Yeah. It is amazing to look at what are the mediators of poverty in attachment, and also that actually that group of children born in that era actually made it out alive, and the role of the midwife and how family strength and family connection was a mediator for the poverty. It's an awesome show, and I would highly recommend it. It's a lot of birthing scenes, so you have to really tolerate that. But it really is exactly this. It's all about the attachment and some of the mediators. My question really talks a little bit more about your experiences as a neonatologist and recognizing temperament very early on in the kids, and talking a little bit about goodness of fit, which is a factor in attachment.
Yeah. Boy, that's a complicated one, isn't it? Because there's so many mediators that affect goodness of fit. So I think you can have a parent who might have started, for example, with a secure attachment with a child who has something happen to them that interrupts that goodness of fit. And one of the things that when I did my program with Edtronic that I highly recommend to people who are interested in this area that we talked about a lot is that the issue is not so much the disruption, but the repair. So as there is a disruption, how do we repair? And I think that's also something that, and please understand, I am not a mental health provider. I don't claim to be. I hang out around a bunch of them. And I think that as we think about particularly working with mothers, fathers, people who are impacted by these life events that happen, one of the things that I try to do, even in the NICU, which is a disruption, is I try to focus on something that's going right. And so I'll just say something like, oh my gosh, look how he looked at you. Do you see how he just looked at your face? Or do you see how she just snuggled in, cuddled in? But, oh my goodness of fit is just, it's dynamic, not static. I think that's the best I can say in conclusion.
Thank you.
Excellent. Okay, so I'm going to combine these two, Marilyn. One is a pretty specific question about are premature and preterm babies at higher risk for insecure attachment, and if so, how much more than the general population? I'm attaching to that. What are your thoughts about parental leave, maternal leave, policy, sort of at a policy level? Where are we as a country? So let's try to wrap those two together.
Sure, I can wrap those two together. The answer is clearly yes. Babies who are preterm are at significantly higher risk for insecure attachment. And there are a number of factors in that, including the fact that up till very recently, parents were considered visitors in the NICU, not the child's primary caregivers. So what I would say is, if you know anybody who has a preterm child or a sick child who's in a NICU, encourage them to be as present as possible, as much of the time, and really assert their role as the primary caregiver. Because too many parents look at the technical expertise that we have and overrate it in terms of its meaning to the child. No, they can't go in and suction the baby on a ventilator. But what they provide, for example, with skin-to-skin contact is extraordinarily meaningful to that child. And then, pardon me, run the second part by me again. I just lost track.
Is more of the policy, a political, world question about, countries that are doing. What are your thoughts about parental leave and?
Yeah, this is a really challenging one. As a mother who's always worked full time and had 3 children, I believe that we should, all things aside, model the Scandinavian countries. I believe that mothers and fathers and, direct caregivers should be able to take prolonged leaves to be with their children after birth and not fear loss of their job and have some financial support in doing that. I wholeheartedly believe that. But by the same token, I believe that this is not a one-size-fits-all, and that there are some people who are very well, whether they are male or female, cut out to be in-home 100% time caregivers, and there's some of us who aren't. And I happen to be one of those who would not have been constitutionally set up to take a year off and take care of a child. I just don't think I could have seen myself doing that. But if we are not doing that, then I do believe that we have a strong responsibility to find high quality care for our children. And likewise, I believe that our country should be providing access to high quality care for all children whose parents either need to or choose to be in the workplace.
Okay, wonderful. And are there studies about a time frame? I mean, is there no one answer to that?
I just don't know that literature that well, John. There may be. I'm going to think that probably somewhere that first year and a half are so important in terms of establishing those early relationships. Not that they can't be repaired afterwards, but I firmly believe that if a mom wants to stay home or a dad wants to stay home and be with their kid for a year, I think we should support that.
Got it. All right, I'm trying to get them in. I'm not going to get them all in, but I'm going to go. This is a pretty specific one from one of our wonderful residents, Dr. Farah Tabaja, and she asks, which I didn't know about this, what are your thoughts about, I think it was called artificial womb technology, or there's your thoughts about the new research being developed with artificial womb technology and how that will affect neonatal development?
Oh my gosh. I can't even begin to speculate the impact that will have, because I think that it's going to be very difficult to have an artificial womb that is a good enough surrogate for the maternal environment, because there's so many dynamic processes. So you could create some kind of a holding place, but the sounds, the tastes, babies drink amniotic fluid, for example. It has taste. So that's, I would worry, but I worry about a lot of things. So great question, though.
I actually had not heard of it until she mentioned it. And she thankfully gave me an article, which I'm dropping in the chat for people if you're interested. All right, there are the 2 other general areas I do want to try to get to, just to preview them for you. One is, of course, about the pandemic. And and one is about adults, and there might actually be some more if we can get to it. So let me ask a bunch of things coming in about the pandemic. What are your thoughts about what masking and distancing and kids, being distanced from their friends at young ages? Do you have thoughts about that from an attachment standpoint? And one further question is, does it affect the clinician-patient relationship?
Well, I'll start with the last first. Oh my God, yes. The impact upon our relationships with patients, I believe, is dramatic, while at the same time, I recognize the necessity of masking. I've had people say to me, I just wish I could see your face. One of the things that I do actually is I had, since our badges are horrendous and they don't really show us, I had a picture of myself made that I wear on my scrubs so that people can actually see my face. And then we also post pictures in the unit. Impact upon children. Oh my gosh. Starting with babies. I think that the impact on babies in my NICU is probably extraordinary. We do not have a single room NICU, so that our parents must be masked when they're in the NICU. If we had a single room NICU, they could have their masks off, except when staff needed to come into the room. So I think that this is an open book question. The impact upon social connectedness, I believe, is huge. I actually have a slide that I wish I'd put in there, because just imagine if we're talking about social connectedness being a biological imperative for mammals, and that would be, of course, whether they are young mammals or for us as older mammals. How do we get our heads around a situation in which if you approach me without a mask, John, you are dangerous to me, right? You are dangerous.
Right.
And I think that the best that we can do right now, and I actually wrote a chapter on COVID for the book where I address a lot of this. The best that we can do right now is to be explicit. And I am explicit with people. How I wish I could. Sometimes, how I wish I could give you a hug, which I'm allowed to do. And use your eyes, use your prosody, your cadence. You have other things. And unless you are wearing an N95 all the time, they can see you smile. Right? Because we all swallow our masks when we smile. So it really calls upon us to think about all those other ways that we can engage besides from here to here. Did I answer that?
Well, actually, yeah, perfectly. And there's a related question to take it to a different level. I think I mentioned we've been doing a lot of work on diversity, equity, and inclusion. There's a question about your last slide on attachment styles. Do you have any thoughts of what's surfaced in this country around racism and particularly anti-Black racism work? Do you have any thoughts around either the way that the pandemic has set us up to do that work, or attachment styles related? It's a very broad question, but are there linkages in your mind between your attachment way of thinking and the eruption of work on racism?
Well, I mean, for me personally, George Floyd was killed near the beginning of the true pandemic, right? So it was very shortly. In fact, I'm thinking it was the end of May 2020, I believe. I kind of have it in my brain. So I don't know whether I can't say directly that what happened to George Floyd was related to the pandemic, but I can certainly say that for many of us who have watched with agony the violence that has erupted in this country, and we will leave it at that because we don't need to go any farther, including the recent violence, they are synergistic. And I think that they take us to very frightening places, because what appears to have happened is that for some of those people, there is no social connectedness.
Okay. Excellent. Thank you. No, that's good. I love it. And I'm going to ask one more, which will take us over just a little bit. And there's a couple I'm not. Evan Fox had a really good one. Liz Birch also. That was the one about adults. But this one I think is a good one to end on. And it's from somebody that says, I'm asking as an ex-preemie mom who essentially camped out in the NICU for 6 weeks. Can you speak to what we know about mom's needs in order to provide an environment where a solid attachment can happen, especially with respect to education and emotional needs of NICU moms?
Yeah. Oh, my, you just fed right into one of my favorite topics. Because I'm very happy to say that after 10 years of trying, I was finally able to get a part-time psychologist in our NICU. 10 years. But I think that there are a number of things. We need to keep in mind that for most, and we'll say families now, but obviously mother is the one that we interact with most. Most families who end up in the NICU with a preterm or otherwise sick baby had no idea prior to a few minutes or days before the birth that they would end up in that unusual environment. So I think that's number one. Number two, one of the things that I really like about the neuroceptive model and the model that Steve Porges discusses, and he's not a clinician, he's a PhD scientist, is that when we talk about behavior from the standpoint of being driven by the autonomic nervous system, we tend to think less about who's difficult, who's challenging, and more about what happened to people. And that's one of the things that I try to do. And I try to get our staff to think in that way too. A lot of it comes out around substance use disorder. I tell them, I think we are all one life crisis away from substance use disorder. It's just a question of, genetically, what were we given as our template and the allostatic load that we're experiencing. And I don't think any of us should be so bold as to say we would never engage in substance use excessively. I think that we need to have environments where mothers, fathers, partners, everybody can feel free to share their anxieties, their fears, their hopes, their dreams openly. That doesn't mean I lie to people. I don't. I am, some people would probably tell you, brutally honest. But I try to do so without an edge. And I think that for mothers of preemies, you've had a huge disruption. Things take time. It may very well be that when you get home, you are not feeling the explosion of love for your baby that you felt sure you were going to experience, because you haven't had that time to have that typical engagement in the privacy of your home as opposed to the public nature of the NICU. I don't know if this addresses that person's questions or not, but
if we were in a room, it would be easier. But I think it's a wonderful idea. And actually, thank you for indulging, to go over the time a little bit. We're just scratching the surface, I think. And there are a lot of people who are saying we need to, if you're willing and have some bandwidth to, think about doing some work with you. I'm certainly thinking about maybe some kind of conference, and there's people with expertise over here and with you and your work. And I don't know if you know Bruce Perry. Have we talked about Bruce?
Of course.
Yeah. A wonderful guy. And it'd be what a conference that would be. So let's put that on, make some kind of commitment to doing some work with you. But everybody, please join me in thanking Dr. Sanders for coming and really dropping some wisdom, as it were, and leaving us, I would say, probably our allostatic load is maybe a little raised with all the things that we need to digest and worry about. And yet, at the end, you've given us an off ramp because you've given us a way to think about it and feel good about that. So thank you. And with that, we can go ahead and stop the recording.
Okay. Bye. Thanks, John.
So, yeah, thanks. That was really